Hello and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss testicular cancer. Being diagnosed with testicular cancer can be devastating for the nearly 10,000 men found to have the disease yearly in the United States. And unlike many other cancers, testicular cancer actually affects younger rather than older men, making the diagnosis all the more traumatizing. But in reality, testicular cancer is often considered a cancer success story. It often results in a good outcome for men diagnosed early and treated appropriately. But how do men know if they have testicular cancer? How can they check to see if they have it? If they are diagnosed with testicular cancer, what are the treatment options? And probably most importantly, what is the prognosis for men with testicular cancer? In order to answer these questions and many more, we turn to a true expert. Dr. Sia Daneshmand is Professor of Urology and serves as Director of Clinical Research at the University of Southern California. He is a leading authority in the management of complex testicular cancers and is one of the highest volume surgeons for this disease in the country. He serves on the editorial board of the Journal of Urology, as well as the American Urological Association and Society of Urologic Oncology Guideline Committee on the testicular cancer. He is a member of the Alpha Omega Alpha Medical Honor Society and has been designated one of America's top cancer doctors for the past 11 consecutive years. He is an active member of the Society of Urologic Oncology, has presented over 400 abstracts at scientific meetings, and has authored over 300 peer-reviewed articles, reviews, and book chapters. And now, without further ado, I bring you our conversation with Dr. Sia Daneshmand about testicular cancer. Hello, and welcome to Better Man Clinics. Today, we're going to be discussing testicular cancer. Now, every year, about 8,000 to 10,000 men are diagnosed with testicular cancer. That's about 1 in every 270 men. Now, while hearing the diagnosis of testicular cancer can be pretty devastating for a man, the good news is that testicular cancer is really one of the cancer success stories. And especially if diagnosed or caught in time and treated appropriately, men can do really well with treatment and overcome this disease. But how do you even know if you have testicular cancer? What do you do to check? How do you get diagnosed? And if you are diagnosed with testicular cancer, what are the treatment options? And once you get treated, how successful are the outcomes really? Well, to answer those questions and many more, we are fortunate enough to be joined by a true expert. Dr. Sia Daneshmand is a professor of urology at the Keck School of Medicine at USC. He's also the director of clinical research there and the director of of urologic oncology. Dr. Daneshmand, welcome to the program.
Great. Thank you so much, Oleg. It's a pleasure to be here.
Thank you. You know, before we dive into the topic at hand, one thing I like to do at the beginning of the program is just to have our viewers and listeners get to know our guests a little bit better. And one question I'd love to ask you is, what inspired you, A, to become a urologist, a urologic oncologist that specializes in cancer, and really also have a specific interest in testicular cancer?
Yeah, good question. As many of us who go into urology, we're drawn to the field because it's a surgical field. We want to be surgeons and fix something sort of immediately and be a specialist in one sort of area and also have this big impact on patients' lives. So that's what drew me to urology. There's a lot of not just surgical advances, technological advances in urology, but also the research that goes on is some of the most impactful, I think, in improving patients' lives. In terms of oncology, again, I was drawn to the sort of bigger questions in terms of impact on patients' lives, and drawn to the bigger surgeries as well. So that sort of drew me to oncology, sort of those challenges in trying to bring the next generation of surgical advances, medications, and things like that to advance the urologic cancer care.
No, that makes sense. And certainly there's hardly a bigger impact than you can make than helping somebody overcome cancer. Pretty devastating thing to hear, but as I mentioned, something that can be a success story, which is great. So let's dive into the topic of testicular cancer. And so first off, with regards to testicular cancer, you know, the concept of all men are created equal, right? Are all men equally susceptible to testicular cancer, or should some men, if you will, be more on the lookout for it than others?
Well, yeah, good question. There are risk factors, not many, but there are some, and many men don't know about these. The most common would be what's called an undescended testicle, is when you're born with the testicles not completely down in the scrotum. Of course, that's not something you remember. That's something you have to be told, because many of those are either corrected surgically or spontaneously will come down into the scrotum later in life. But if you've ever had surgery or been told by your parents that you had to have surgery to bring one of the testicles down into the scrotum, those patients are increased risk. Having a first-degree relative, brother, father, also puts you at increased risk. And then the others are not controllable. Race, white men are increased risk of getting testicular cancer compared to African Americans and Asians. So those are the sort of most common risk factors cited.
Got it. And so like when we talk about other male cancers, like for instance, we talk about prostate cancer, right? People say, oh, you know, that's a cancer of middle-aged men, older men. Is that the case also for testicular cancer, or is there a different age group involved?
No, it's a completely different age group. You're right. In prostate, you know, we're diagnosing men in their 60s, 70s, 80s, whereas testicular cancer is really a cancer of young men. The typical age range is about from 15 to 35. So that's where the peak is. It's in the mid sort of 20s to 30s. There are two types of it, and I'm sure we'll talk a little bit about the different types. But typically, you know, it peaks in the 30s. There's a slight peak in the older patient population, but those are different types of cancer. So really, it should be thought of as a young man's disease.
Yeah, I mean, that's partly part of the scary part, right? Because young men are definitely one thing young men are not thinking about is cancer. And so that goes to the idea of diagnosis, right? And so whereas older men probably going to their doctor, getting that annual checkup and keeping on top of things, young men, you'd have to drag them to a doctor, you know, at that door, you know, because like, what am I going to do at the doctor, right?
Exactly. So, they feel invincible, you know.
Exactly right. And so
right.
like, unfortunately, that's one of the reasons why we're having this conversation as well, because obviously with any cancer, the sooner, the earlier you identify it, the better chances of success. So to that end, you know, guys are sitting out there and thinking, okay, I'm game. How do I know if I have cancer? Or first of all, are there any symptoms that I might notice if I were to have a testicular cancer, for instance?
Okay, so the most common would be a lump in the testicle. Men are really not used to checking their testicles all the time. So in fact, they're pretty bad at it. When a lump develops, they say, I never noticed this. It's so the first thing you can do is just check both testicles. It should be smooth, symmetrical. There should be no lumps or bumps or heaviness to the testicle. Often these are not symptomatic. They're not painful. Just because you don't have pain doesn't mean that there's no tumor there. So it's usually not subtle. It's usually a hard lump that's actually typically painless. In our terminology, we call it the painless testicular mass, as opposed to the painful ones, which are oftentimes associated with infection. So that's really the best way to discover a tumor early in its process when it's small, and fairly manageable, as opposed to coming in when the testicles, 2 to 3 times the size of normal and sort of been ignored for this time. The symptoms of spread, sometimes the testicular tumor is actually small, and unfortunately it spreads very quickly and spreads to the back of the abdomen, an area called the retroperitoneum, the back of the abdomen where the spine is. All the lymph nodes are located back there. So that's the first route of spread. And oftentimes these lymph nodes get enlarged and cause back pain. So unfortunately, in young men, back pain is common because, they're playing games and athletic and they thought they just hurt their back. But if something's unusual and you can't attribute it to a game or sports or any kind of activity, then again, that requires a further workup.
Now, you mentioned doing an exam. Now, this is going to sound like a weird question, but most guys aren't, actively checking their testicles on a daily basis. Is there a right way to do a testicular exam, like for guys at home?
Well, yeah, not really. There's no real right way, but the way we tell them is basically feel the testicle between 2 fingers and your thumb. Typically, the best place to do it is in the shower with soap, so it can be smooth, and you don't have to hurt yourself. You just go basically back and forth and feeling that smooth capsule of the testicle. Now, people sort of freak themselves out because they feel the top of the testicle, an area that you and I know is the epididymis. Yes. That's where the sperm sort of collects and goes along in its tubes. That's a normal sort of a mushy feeling, and occasionally there's some little cysts that feel like a pea, like a green pea, and can be fairly hard. But that's not the testicle. The testicle itself is just smooth, round. Look, you can just Google what a testicle looks like in a figure form and sort of see the anatomy of the testicle and see what you're feeling. But that's all you're looking for. That's all we look for when we do the exam, right? So we just feel for that smooth surface of the testis.
And is there a frequency? Like how often or is it recommended for guys to do that exam?
No more than once a month in that age range. We don't want to scare people. It's far less common than breast cancer, but it's a very, very easy thing to do. So once a month is more than enough.
Got it. So let's say a guy is doing that, following your instructions, they go and check and they feel a bump. They're not sure, is it really on the capsule or maybe it's on the epididymis, just they feel something and they've already kind of freaked out, which is normal and pretty expected. What do you do at that point?
Yeah, so they come to see us at that point, and if we think there's an abnormality, or sometimes they feel something that we can't feel, then really the next best step would be a scrotal ultrasound. Ultrasound is very, very sensitive in picking up any abnormality in the testicle. So it's a very simple exam to do. It's basically exactly what you imagine. It's our ultrasound probe that's put on the scrotum with some gel, and we go back and forth. It can be done in the office with some urologists are comfortable doing those, or a radiologist's office. And it gives us real detailed architecture of the inside of the testicle, and we can really completely rule out a testis cancer right there and then and say, look, this is absolutely normal. What you were feeling is some little tiny thing on the capsule of the testis. So it's an easy thing also to do. But the opposite, don't ignore any masses thinking, oh, this is fine. Just go see a urologist. And sometimes primary care physicians are not equipped to manage this, or they don't know what it is, or they give antibiotics for presumed infection. They're not really thinking about testis cancer. So really should be evaluated by a urologist who is the expert in management of these types of ailments.
Got it. So one thing I like to do, and you kind of covered it partly here, one thing I like to do is guys get very nervous about going to the doctor, right? So they'll put it off as much as possible. So not to kind of oversimplify, but if somebody's coming to your office with a lump, can you just go through the things that they're going to do? I'm assuming you're going to do an exam. You say you might do an ultrasound. Are any laboratory tests required usually at that time as well?
Yeah, so if it's a true lump, first of all, we're friendly people, right? If you realize, we don't scare too many people, but so yeah, absolutely. There are lab tests. There are these what we call testis tumor markers, which are lab tests that help us diagnose and also help us in treatment of these testicular cancers. So if there truly is a lump that we can feel, and the ultrasound is real, it shows us a tumor, then yeah, the full workup would be also to draw these labs called tumor markers. And there are three of them classically called AFP, beta, HCG, and LDH. The HCG is the same one as the pregnancy test, incidentally, and the exact same hormone that's produced by some of these testicular tumor testis cancers. Not all cancers produce markers. So just because you have a completely negative marker profile doesn't mean you don't have testis cancer. And vice versa, slight elevation of one of the markers or two of the markers doesn't necessarily mean you have testis cancer either. You just sort of have to put the whole picture together.
Got it. So, and at the same time, let's say this guy is in your office, you feel something a little suspicious, you do an ultrasound, it shows something a little suspicious, even the markers may or may not be elevated. That's not a diagnosis of testicular cancer yet, right? Or is it?
Well, yes and no. So if the markers are very elevated, we pretty much 100% know there's hardly anything else. There is nothing else that can produce markers to high levels. Let's say your beta HCG level is 1,000, you have a lump, AFP is 500. We have the diagnosis there. However, we still need to remove the testicle and get the real diagnosis, the histology, what it looks like under the microscope to give the full picture of what type of tumor it is, what kind of treatment we're going to be prescribing here going forward, or is that it? You know, it could be just a removal of the testicle called an orchiectomy. We at that point would need a CT scan of the chest, abdomen, and pelvis to make sure that the testis cancer hasn't spread to the back of the abdomen. Those lymph nodes in the back of the abdomen. So that's part of what we call the staging workup, and something we do for all cancers. So, you know, first step is exam, ultrasound, labs. Then if truly there is a lump and there is, you know, the diagnosis of potential testis cancer, we remove one of the testicles. And then somewhere in there, we're doing a staging CT scan of the chest, abdomen, and pelvis.
Got it. So let's take one step back. So let's say we found this small mass in the testicle, and you say, you know what, we strongly suspect this is testicular cancer. It's 95% is. You said an orchiectomy to remove the testicle. Now, a lot of guys that are out there will ask the question, well, why can't you just remove the mass and leave the rest of the testicle? Leave my testicle alone.
Yeah, very, very good question. And if it's a small mass, it can be considered. The problem is that it's generally not in just one area. It is actually uncommon for it to be a small mass in one side of the testicle, or what we call one pole, where we can do a partial orchiectomy. The recommendation is to do a total orchiectomy because, again, there'll be other areas within the same testicle that will harbor sort of the beginnings of cancer. And so the patient would be at high risk of developing other tumors within the same testicle. So if you have two normal testicles, then or you know, one contralateral, your other testicle is normal, then we would generally recommend a radical orchiectomy. Now, radical just means removal of the whole testicle and the cord that gives the blood supply to the testicle. Now, occasionally, you brought up a good point. What if you have a small mass, you're really unsure, your tumor markers are negative, the mass is 1.5 centimeters, and you're really not sure even if this is cancer? You brought up a good point. It's 95% cancer. You're absolutely right. It's about 95, 96% that it's cancer, but 4 or 5% that it's not. We can do a partial orchiectomy in those cases. There are some benign tumors of the testicle that mimic cancers. They're just benign. They're called Leydig cell tumors or Sertoli cell tumors, and occasionally even cysts of the testicle. So one of the recommendations that we have in the AUA guidelines, the American Urologic Association guidelines on which I serve, if the mass is less than 1 centimeter, then we don't recommend surgery. We actually recommend a surveillance period where we watch these, because most masses actually under 1 centimeter are going to be benign. So size does matter in testicular tumors, and we don't want to be, as you said, taking out a whole testicle if there's a 4 or 5% chance this is not going to be cancer.
And public service announcement here, when you say surveillance, that means under a doctor's care, not the guy should be just saying, oh, it's less than a centimeter, I'm just going to keep an eye on this myself and get back to you, correct?
Absolutely. Surveillance actually means ultrasound, serial ultrasounds, because we want to compare the size, not just by exam, but what we feel. We're going to forget what it felt like 3 months, 6 months later with all the patients we have, but we actually want documentation with the ultrasound of what this looks like serially.
Got it. So let's say, again, we're not in that scenario. It's a mass that's big enough to warrant an orchiectomy. I'd love for you to walk us through a little bit of that experience. First of all, you mentioned orchiectomy is removing the testicle and the cord that connects to it. Where is the incision actually made, and what happens during the actual operation?
Yeah, so not to get into gory details, but it's actually not gory at all. It's people imagine that the easiest way to get to the testicle is an incision through the scrotum and remove the testicle. Well, decades and decades ago, that was associated with high local recurrence rates, which means the tumor would come back in the scrotum. They realized that you really need to remove the testicle and the cord that supplies the blood to the testicle all the way up to the inguinal area. That's the groin area. So again, decades ago, it was established that we need to make the incision, a very small incision, depending on how big the testicle is, right over the groin, get down to what we call the external ring, where hernias are felt sometimes in older men. And then, bring up the testicle into that groin area and remove it along with the cord. So it's a very simple operation for us, and it's usually outpatient, and the incisions are small, and the patient generally, if we're doing this on a Friday, can be back in school or work by Monday. It's slightly uncomfortable for a few days, but generally no need for opioids and Tylenol, Motrin, Advil, that type of thing. Now, a couple of things before, and I'm sure we'll get into these discussions, is before we do the orchiectomy, we're having discussions about sperm banking for fertility, because even though the testicle may contain cancer, there are normal parts of the testicle, and you want to maximize the sperm that you want to bank, just in case there's some infertility associated with this testis cancer diagnosis. You want to sort of maximize the sperm that's present. Now, if you don't do it, it's not such a big deal. You still have the other testicle, presumably that's producing sperm, and in most cases will actually completely take over both the function, which is testosterone, as well as a production of sperm completely normally. So you don't need two testicles, just like the paired organs in the body. Most of them, you only need one, like the kidney. So once we do the orchiectomy, the patient recovers and comes back and sees us about a week later for postoperative follow-up and a wound check. Complications are really quite rare. Rarely, you have a little bit of a hematoma or a collection of blood in the scrotum, or something like that. It goes away. One other thing I should mention is during the consultation, we always have a discussion about a testicular prosthesis placement. Just like, women have their breasts removed and have a breast prosthetic placed. We also offer men a testicular prosthesis. It's a saline-filled prosthesis that's very realistic, and we actually published a study asking patients about their satisfaction with these prostheses, and it was a high satisfaction rate. They would recommend it to a friend. They would do it again. About 90% of men would say they would do it again, so that's something that's placed at the same time. Very easy to do.
Got it. And I'm assuming if they decide not, they can always do it later too, or no? Or
it can be done later. It's a little easier to do it at the same time, obviously, but yeah, absolutely, it can be done later as well.
Got it. And so, like, once the surgery is done, kind of that shock and awe is over, it's behind you, kind of the tumor is out. You go back to see the doctor, and you said do a wound check, everything's okay, and now we have to talk about the actual cancer. So once you, as the urologist, the surgeon, get that pathology report back, Is it all the same? Is it just testicular cancer, or are there different types of cancers and different outcomes based on what they find?
Yeah, definitely different types. I get into some detail with the patients because it does matter. There are two general lineages of testicular cancer. One is called a seminoma, and it's what generally is called a pure seminoma. Everything you're looking at under the microscope is seminoma. It has a particular sort of architecture to the tumor. And then there's non-seminoma. Now, within non-seminoma, you can have some seminoma in there as well, but non-seminoma means that you have some non-seminomatous elements. And then those are broken down into other subtypes like embryonal cell carcinoma, choriocarcinoma, and yolk sac tumor, things like that. So typically you'll see a mixed picture with the non-seminoma tumors. Now, the reason we get into the weeds with that is because the treatments are a little bit different and the outcomes are a little bit different. Seminomas tend to be in older patients, older meaning in their 30s, whereas non-seminomas tend to be in the younger patients. But certainly you can have either or in younger and older patients. Now, seminomas are usually slower growing, usually better prognosis in terms of overall outcome. And non-seminomas tend to spread a little bit easier. They spread to different parts of the body. So it does make a difference. And certainly from a treatment as well as a surveillance perspective, it makes a difference whether we have a pure seminoma versus a non-seminoma.
So, obviously not jumping too much in the weeds, but I want to give the guys a little perspective of what different buckets, if you will, of diagnosis are. So the first scenario is, let's take the seminomas first. So let's say you have a guy who had an orchiectomy. He had his CT scan. It didn't show any spread. His markers looked okay. So we assume that luckily, fortunately, the cancer was found was removed before it left the testicle, and it's a seminoma. In that situation, what is the usual recommendation? What happens next?
Okay, so presumably, so there's no spread, the CT scan is negative, the markers are negative, then you have what's called a stage 1 seminoma. Stage 1, it's in the testicle, we removed it, and the cure rates are extremely high. They're about 85% with the orchiectomy alone. So what happens to those 15% of patients? They do, at some point during their follow-up, have a recurrence, a relapse, typically, again, in the back of the abdomen. So let's take seminomas, for instance. Seminomas are very predictable in their recurrence. As I mentioned earlier, they grow fairly slowly, generally, if they haven't spread already. So you'd be stage 1, and we would do a CT scan periodically to look for these recurrences. Now, recently, we've really streamlined our follow-up, and we'll be publishing on this pretty soon in terms of getting the blood markers and the chest x-rays and the CT scans. Well, it turns out almost all of these we pick up by CT scan alone. So the markers are not so helpful in seminomas. So we do these surveillance imaging basically to pick up these recurrences, and you'd get the first one around 3 or 4 months, and then every 6 months for 3 years, because they're, again, it's predictable. Once you do have a relapse, it's highly, highly curable. Almost all patients with stage 1 seminomas, literally 99 to 100% of patients are cured one way or another. So we highly recommend surveillance and not additional treatments like chemo or radiation or anything like that, because the cure rates are very high. And those 15% of patients who do relapse, we can offer additional treatment to, whether it's chemotherapy, surgery to remove the lymph nodes, and that's about it. We're not recommending radiation these days for seminomas. Non-seminomas are very similar. It's just because of the slightly higher risk of it coming back, it would be anywhere from 15 to 50%, depending on the characteristics and the architecture that I was talking about. There's some little nuances within the testicle itself, within the tumor, that alert us as to this is a higher risk or low risk of recurrence. So those patients we follow generally a little bit closer. We do the blood markers, we do chest x-rays and CT scans of the abdomen to look for these recurrences, usually every 4 months in the first year. Then after the first year, again, it goes back similar to the seminomas every 6 months up until year 3. Now, we don't stop at year 3. We also do an annual at year 4 and year 5. And after that, it's a discussion of what we should be doing, because recurrences are quite rare after 5 years. So it depends on the patient. It's called the provider-patient sort of a decision-making in terms of how you want to follow this for the following 5 years. But certainly, most patients are cured after 5.
So whether it's seminoma or non-seminoma, if it's localized to the testicle at the time of surgery, it's usually not recommended to do any type of, if you will, adjuvant therapy, the chemotherapy up front, radiation up front, surgery up front. It's not recommended.
So yeah, let's take seminoma because that's easier. And I think there's more consensus on that. For stage 1 seminoma, all around the world, the guideline recommendation is for you to do surveillance and not give additional treatment. Because like I said, 85% of patients are cured. And the ones who do relapse, we give additional treatment and those are cured. So you really reserve the additional treatment, which can be toxic, chemotherapy and surgery. There's some side effects. You really reserve those for the patients who relapse. And 85% were cured with the orchiectomy. You don't give them any additional sort of toxicities of treatment. In non-seminomas, depending on the risk, there is some controversy in the high-risk patients who are 50% chance of relapse, where some centers, some countries, like in Europe and Germany, they do offer 1 or 2 cycles of chemotherapy to bring that 50% risk of relapse down to 3 or 4%. About 3 to 4%. But here in the U.S., we still, it's controversial whether we do surgery or surveillance, because again, 50% of the patients are cured. My approach has always been surveillance, because I'll talk to the patient and say, look, there's a 50% chance you're cured. There's a 50% chance you'll relapse, and at that point, we'll give you chemo, and almost guaranteed you'll be cured. When I say almost, I'm talking about 99%. I'm not saying 70, 80%. But so patients have to realize that the decisions they make, this is not like other cancers where if you don't treat early, we'll miss the opportunity for cure. No, unfortunately, we have that safety net of chemotherapy later on to catch these relapses, provided they follow up and do their surveillance. Now, we get into compliance and, is the patient going to follow up? There's no way we can predict patients' behaviors. You'll have the lawyer who's very successful, we think is going to follow up, will not follow up. And the blue collar worker who we think is not going to follow up is the one who does all the follow up. So compliance, I think, should not be in the discussion. Even patients who are non-compliant, unfortunately, will show up to the ER or somewhere with a big lump somewhere or pain, and they also can be cured, because the biology of patients who present with stage 1 disease is such that the tumor will not, go to the brain or the liver or the bone. They generally will go to the back of the abdomen, the lymph nodes, where it is highly, highly curable.
Yeah, that's a bit of a paradigm shift, right, for people to get their minds around, because for most cancers, once the horse is out of the barn, pardon the expression, they figure, the thought is, we can no longer cure you. We can try, we can give you all kinds of things, but it's not a very optimistic scenario. But in testicular cancer, it's completely different, it sounds like. That's
exactly right. Yeah. And the other spectrum of the diseases, I treat bladder cancer a lot, and it's the complete opposite recommendation, where we have risk factors and we go to radical surgery and remove the bladder and do all kinds of reconstruction, because if we miss our opportunity for cure, the patient will die of their disease. We don't have adequate treatments for metastatic bladder cancer. They're getting better, but for testis cancer, fortunately, we have lots of very, very effective treatments, especially again when you're stage 1. So we don't want to be doing, the paradigm shift here is not doing all these preventative things that are hurting the patients who are already cured. So that was an idea in the 70s and 80s and maybe early 90s, but even then they started realizing, wait a minute, maybe we're doing too much to these patients. Now that we've discovered the cure, let's back off and allow these patients to enjoy normal life without further treatment. There's always a discussion. There's always a long discussion with the patients to make sure they understand what's required, what the recurrence rates is, and all that stuff. But of course, we're here to guide them. And I always draw these things out on a piece of paper, and I start at the very top. I go, here's your survival, 100%. Under my care, your chance of survival is 100% with this cancer. So let's see how you want to get there. And we go through surveillance, chemo, potentially radiation, and on all these things. So almost always, patients will choose surveillance when you present it to them that way.
So you brought up a good point in terms of doing too much, right? First, do no harm, right? What some patients or some guys might say, listen, I'm a young guy. I'm in my 20s or 30s, and you're saying, well, for surveillance, though, I need to get a CAT scan every 3 months or 6 months or a year. Doesn't that pose a risk to me as well, just from the radiation of the CAT scan?
You've opened up a big can of worms. Oh, like,
I live for this. This is my version of controversial.
Right. There's so much out there that, people thinking. I have patients in their 70s, 80s come and tell me there's radiation risk. Listen, yes, there's some risk, potential and theoretical risk to radiation. That risk, we call it a risk-benefit ratio. The benefit of getting the CT scan far outweighs the potential and theoretical risk. The reason I say potential and theoretical is none of this has actually been proven yet. Everything is based on models of radiation in Hiroshima and all these people who got cancer. So it's these mathematical models of what the human body can tolerate. There's radiation all around us, by the way. We all know this. And the higher up you go, the more radiation. So you take a transatlantic flight, you're getting radiation to the body. The body is extremely resilient. If we would be getting cancers day and night if it was affecting us. But in response to that, what we've done actually is we've streamlined the imaging, both intensity and also what we're imaging. So intensity meaning how many CT scans we're doing. In the past, we were doing them every 3 months. We were doing chest, abdomen, and pelvis. So yes, for a young man, getting 20 CT scans may be crossing that threshold to increasing a risk of getting secondary malignancies in their 50s and 60s, potentially. So what we've done at our center is, for instance, I told you we do an initial chest CT scan, and if it's stage 1 disease, we no longer do chest CT unless it's absolutely necessary. So chest X-rays only, which is 1/1000th of a dose of a chest CT. The other thing I've done for the past 10 years is, as you know, CT scans come in abdomen and pelvis. Well, yes. Ironically, we don't need the pelvis portion of this, right? The testicle is there, it's gone, but this spreads to the back of the abdomen, not the pelvis. So we've actually eliminated the pelvis CT scans for the past 10 years, and we're only doing a low dose CT of the abdomen in prolonged, surveillance intervals. So, initially 4 months, then every 6 months, you end up with 6 CT scans over the span of this 6 CT scans of the abdomen is really very, very minimal in a low dose protocol. So we're pretty happy with that. And we have a new study coming out showing that we haven't missed a single cancer with that approach, single cancer recurrence.
Well, that's certainly very reassuring. Now, let's talk about the 15% that do recur. Obviously, it's extremely reassuring to that number of 100% can't get more reassuring than that. But at the same time, guys know if I'm in that 15%, I'm in for something, right? I have more treatment in store for me. I know you mentioned chemotherapy versus surgery. Can you, obviously on a high level, explain a little bit about what those options are and how they might, what the patient may experience with one or the other?
Yeah, absolutely. So if it all depends on what the recurrence looks like. If you come in at 3 months and your markers are elevated and you've got 2 little nodules in the lung and a few in the abdomen, well, the tumor sort of spread in multiple different places. It's a no-brainer. You need chemotherapy, which again is extremely effective. And the chance of requiring additional treatment after this first round of chemotherapy, it's a 3-cycle regimen of 3 drugs called BEP, bleomycin, etoposide, and cisplatin. those drugs will essentially cure the patient. So, but some patients will develop just a lymph node in the back of the abdomen, and 3-6 months later, there's a lymph node in the back that's grown a little bit. It's still confined. We do a additional workup. The markers are still negative. Well, those patients have an option. They can either have chemotherapy with the same cure rate that we were talking about, or they can have surgery to avoid the toxicities of chemotherapy. So we offer a surgery called RPL and D, and many other centers, of course, retroperitoneal lymph node dissection, where we go in the back of the abdomen and remove these lymph nodes with a very high cure rate, all for to be able to avoid the toxicities and late toxicities of chemotherapy. So that's an option for patients who have isolated, small volume, marker negative retroperitoneal relapses.
And if you surgically remove that little lymph node or collection of lymph nodes, you're technically curing them again. They don't need anything beyond that potentially.
Exactly. That's the point of the surgery. We don't do the surgery and then give chemo. We used to, if we found a lot of lymph nodes, we used to recommend, additional chemotherapy just to make sure. But again, that same concept of let's do the minimal possible to cure the patient. And if they relapse, they need the chemotherapy. So we rely on the safety net of chemo if they relapse after our surgery. So yeah, when we go in for surgery, almost always that's going to be the only treatment for that time period. And then you go back on surveillance and we watch the patients again with CT scans.
So when we talked about the orchiectomy surgery, the one to remove the testicle, it sounded pretty, every surgery has risk, but it didn't sound particularly onerous. It sounded kind of like a hernia surgery. Guys aren't particularly worried about that. What's involved with this type of RPL and D surgery? Is it done like with a big incision? Is it done with cameras, laparoscopically? Can you give us an understanding of what that might involve?
Sure. Yeah. Kind of this is a much more complex operation, and we really recommend that the patients seek out centers of excellence or centers where they do this often. This is not a hernia. This is not an orchiectomy. This is something that requires expertise, and it's not a common operation. So many urologists who are excellent surgeons are not really all that trained, or they haven't done too many of them. They're not comfortable with the operation. So they themselves will refer the patient sometimes to higher volume surgeons. Now, these are done usually through an open incision down what we call a midline incision down the middle of the abdomen. And we get to the back of the abdomen where these lymph nodes are located in the retroperitoneum. The peritoneum is a sac that contains the intestines, and we're going behind that sac and removing these lymph nodes in a predefined sort of map of boundaries and borders of where we're supposed to remove these lymph nodes. So the operation is technical. It does take several hours to do because we're in and around the what we call the great vessels, the aorta and the vena cava. And so we have to do a very thorough job. This is not just removing 1 or 2 lymph nodes that are involved. Like I said, we have to remove the lymph nodes in the predefined sort of boundary so that we don't have a recurrence in those areas again. So very technical. And that has evolved a lot. The way I do the surgery is the peritoneum is a very, very thin sac. It's literally like a balloon. It tears very easily, but I separate the peritoneum from the abdominal wall, and I actually go behind it in a procedure called an extraperitoneal procedure. So midline incision, I try to make the incisions quite small, go behind the abdomen, keep the intestines all within their sac, and just remove the lymph nodes in the back and lay the peritoneum back. It really expedites their recovery. So at our center, patients are going home the next day after this operation, which used to be a 4, 5, 6, even to this day, 7-day hospital stay. But recently, well, not recently, I've been doing this for about 10 years. But we've been recently sending patients home the next day because they're eating and walking around and doing well, and the incisions have gotten smaller and smaller. So it is a little bit variable between centers of how they do this. The traditional way is a big long incision and bringing all the intestines out so that you can get to the back of the intestines. But this technique, which hopefully should propagate a little bit more around the country and the world, really expedite the recovery and makes it a much more tolerable surgery. And then that in turn will get into the discussion of when you say chemo versus surgery then becomes a little bit more tolerable and more, this is not the same old RPL and D that when I was training, certainly we made huge incisions and the patients were in the ICU for a day and, 4 or 5 days with tubes in their nose. And I mean, it's very, very different. So now we'll get to that discussion. We don't have all that much time, but the more advanced cancers where they show up with big masses, these things can be absolutely gargantuan in size. The patients will show up with a belly full of tumor, and the tumor spread very early on in the process. They get chemotherapy and the mass shrinks from a watermelon size down to melon size. Those are big operations still. And occasionally we need to go in there. These are 6, 8, sometimes 10-hour operations where we need to remove the mass, sometimes even surrounding organs for a cure. And the cure rates are a little bit lower in the more advanced settings. Some of the biggest operations I've done in my career have been these testis cancer tumors, ranging again from anywhere from 4 hours to 16 hours. I was in the OR one time for 17 hours actually in one of these cases. So they can be really, really challenging when they're very large, involving all compartments of the body and things like that. But the smaller ones, the more common ones, we're doing in about 3-4 hours and the patients are doing quite well.
One quick question and then we'll finish off with the more advanced cancers. One quick question, just in terms of everyone's talking about robotic surgery for anything cancer, right? Even the cancerous hangnail should be robotically removed because it's better that way. What are your thoughts about robotic surgery for RPL and D?
Yeah, I'm often asked to do debates with my colleagues on robotic versus open surgery, and I think it's fine. There's some in some settings. I think it's feasible. Again, it has to be a surgeon who is very well versed in doing this operation. The bar is set so high in terms of success. I think there are lots of issues with training enough trainees, urologists to do this operation. There is a handful of surgeons around the country who do this on any kind of regular basis, literally a handful. I can count on one hand how many there are who do this routinely, robotically. So these are part of some of the issues. Not enough cases have been done. Certainly there are some very talented people who do it and do it well. One of the concerns we've always had is tumor spill. If you have active tumor that with the gas that we put in the abdomen to insufflate the abdomen, if you have a little bit of a tumor, that the gas will kind of spread it in areas. There have been some reports of these things happening. This is always a debate. But certainly with robotic surgery, the cosmesis might be better. You do end up with 6 different holes in your abdomen versus one short midline incision. I'm not sure that's all that different. In some centers, the convalescence or the hospital stay and recovery is quicker with robotic surgery. So that's something to be considered. But again, I told you that with this midline extraperitoneal approach, we're sending patients home the next day. That's certainly not the case. It depends who you're comparing to. So, the debate's always the open surgeries, the traditional way, may be associated with more morbidity in some centers. So people are trying to push the envelope with robotic surgery. But after 20 years, we still don't have robust data to tell us that it's equivalent. And there are colleagues of mine who are trying to sort of start these clinical trials to prove the equivalency in the next, hopefully, 10 years or so.
Yeah, it sounds like with RPL and D, there's a lot of art there. And this is kind of where you really do want to seek out somebody with the experience and expertise to do it. It's not like the orchiectomy where you said, any urologist can basically do that, right, versus this where you really want to seek out an expert. Exactly. Now, let's finish off with the other scenario, which is the scenario of somebody gets an orchiectomy, that's all well and good, but either on the CAT scan or their tumor markers or both, there's sign that the tumor has already spread before the testicle was removed. First question. You mentioned with the earlier scenario, really the success rate is 100%, 99 to 100%. I would assume this goes down with more advanced cancer. What's the prognosis like for guys with that scenario, the one where it's already spread?
Right. So we have stage 1, 2, 3. We talked, all the discussion so far has been on stage 1, where it's in the testicle only. Stage 2 would be limited number of lymph nodes in the back of the abdomen, and stage 3 would be spread beyond that. So when you present with stage 2, you sort of have that option. We talked a little bit about it, where you can either do chemotherapy or surgery to remove those lymph nodes for non-seminomas traditionally. And recently, we just finished a trial showing the same results with seminomas in a trial called the SEMS trial, surgery for early metastatic seminoma. So that's for stage 2. Early stage 2. Stage 2 goes up to some bigger masses. So the bigger the mass, the more the spread, you need chemotherapy first. And it's very, very standard. All around the world, it's the same regimen. So you should be getting either 3 or 4 cycles of a 3-drug regimen, BEP, or in some centers, they do 4 cycles of EP if you want to skip the bleomycin that has some pulmonary toxicities, but generally very, very well tolerated. So the standard of care around the world, I would say, is BEP times 3. 3 means 3 cycles. Each cycle is about 3 weeks, so the whole thing takes 9 weeks. And generally, then we do a CT scan afterwards to see what has happened to the masses wherever it was. Generally, anything in the lungs will disappear. Occasionally, there'll be 1 or 2 little lesions left that we need to either follow. Rarely, they actually need surgery to remove those in the lung. And then the back of the abdomen, we have these very strict rules about when we go in to do the RPL and D, the post-chemotherapy RPL and D. If any residual mass in non-seminomas is more than 1 centimeter, then we go in and do a post-chemo RPL and D, clean up the whole thing. If it's disappeared, we don't see anything, no need for surgery. Seminomas are a little bit different. They're very, very chemosensitive. So our threshold for doing surgery is a little bit higher. So if the mass is less than 3 centimeters, we don't do surgery. And if it's more than 3, still it's a consideration, because most of the time the mass is completely treated with the chemotherapy.
Got it. And again, in terms of prognosis for those stage 2 and 3 diseases, what kind of numbers can you quote?
Yeah, so we do have these risk factors. There's an international germ cell consortium called the IGCCCG consortium that puts patients into good, intermediate, and poor risk. And that has to do with their prognosis. So stage 1 is excellent. We talked about the 99%. Stage 2 is 95%. Stage 3, you start to get into the, depending on the risk factors, and the risk factors have to do with your tumor marker elevation. If, for instance, your markers are 50,000, your AFP is greater than 10,000, beta HCG is more than 50,000 to begin with, those patients fall into the poor risk category, and the survival rate or the cure rate would be in the 70% range, in the 75% range. So we do see quite a drop from the stage 1s and 2s down to the poor risk stage 3s. And those typically will require not just the first round of chemotherapy, but oftentimes the tumor comes back and they need a second round of chemotherapy called salvage chemotherapy, potentially surgery on top of that. So really intensifying the treatments for the real advanced disease. Now, those are patients who present with advanced disease, like you didn't have an opportunity really to catch it. So, there's not much. So early diagnosis is still key, but unfortunately, some of these tumors, they're very small and they metastasize very early. So you can't really catch those early.
Yeah, I guess the fortunate part is that for the vast majority of patients, truly a success story, and really can't say enough to really look out for it, get checked, check yourself, and don't be afraid in terms of kind of seeking help, because this is a success story and we want to get you across the finish line.
Right.
Daneshmand, thank you so much for your time and for your insights. This was extremely insightful and helpful for a lot of guys out there. Before we let you go, I'm going to ask you a question. I'm assuming completely unrelated to testicular cancer. This is called this podcast called Better Man Clinics. The idea here is that we're trying to get guys better every which way we can. You've obviously reached a significant level of success personally, professionally. What's the secret to your success? How do you live your best life?
I don't know that what the secret is. A lot of successful people in my world, but I absolutely love what I do, and I have fun with it. People think, oh, I tell them I do cancer, and they go, oh, it must be so sad. It is, but it's also extremely gratifying too to be in a position to be able to help these people. It sounds cliche, but it's really true. I go to work, I'm super happy. I see all these patients who we've cured, where they're on surveillance, and even when there's a recurrence, we have solutions most of the time for these patients. So to me, it's not a sad field; it's a happy field to be able to be in a position to help these patients. I'm super excited about new treatments all the time. I'm thinking what we can do to make things better for patients. What are the other treatments coming along? And I do a lot of research in testicular cancer and other cancers. So it just keeps it exciting. I think you need to be excited about your work to make it fun and make it look like it's not work.
Love what you do and it'll lead to success, but your passion and enthusiasm is palpable, and your patients are certainly lucky to have you. Dr. Daneshmand, thank you again so much for your time and your insights. And for all of you guys out there watching and listening, thank you for joining. And remember our mantra here at Better Man Clinics: your best life is a journey and not a destination. Use every single day to get just a little bit better. We'll see you all next time.
Thanks, Elliot.